Bismillahir Rahmanir Rahim. The term gluten-related disorders refer to a spectrum of different clinical manifestations triggered by the ingestion of gluten in genetically susceptible individuals, including celiac disease, wheat allergy, and non-celiac gluten sensitivity. Gluten-related disorders are characterized by a large variety of clinical presentations with both intestinal and extra-intestinal manifestations, including the skin. In my previous video, I talked about celiac disease and its cutaneous specific manifestation, dermatitis herpetiformis. In this video, I'm going to talk about the other two categories, wheat allergy and non-celiac gluten sensitivity. Welcome again to Derma Immunology. I'm Naglaa Elmongy, Professor of Dermatology, Cairo University. Here is again my reference, which is published in Frontiers Medicine, May 2023, Skin Gluten-Related Disorders, New and Old Cutaneous Manifestations to be Considered. Starting with wheat allergy. Wheat allergy is an adverse immunological response mediated by immunoglobulin E antibodies to wheat proteins. These IgE antibodies specifically recognize and bind to allergens in the wheat, initiating a cascade of inflammatory reactions. The manifestation of wheat allergy can vary depending on the route of allergen exposure and the specific immunological mechanisms involved. Symptoms may present as food allergy affecting the skin, gastrointestinal system, or respiratory tract, food-dependent exercise-induced anaphylaxis, occupational conditions like asthma and rhinitis, or as contact urticaria. Wheat allergy is a separate condition from celiac disease where the immune system reacts specifically to wheat proteins, but it does not involve an autoimmune response like celiac disease. Celiac disease is an autoimmune disorder in which the body's immune system attacks its own tissue upon gluten consumption. The prevalence of wheat allergy in both children and adults is approximately 1%, ranging from 0.4% to 4%, varying based on the patient's age and geographical regions. Children tend to have a higher prevalence of wheat allergy compared to adults. This higher prevalence in children can be explained by the fact that many tend to outgrow the allergy by the age of 16. Wheat allergy can present with a range of symptoms including urticaria, angioedema, asthma, allergic rhinitis, abdominal pain, vomiting, acute worsening of atopic dermatitis, and wheat-dependent exercise-induced anaphylaxis. These symptoms can typically begin within 2 hours following the initial exposure to wheat. Most children with wheat allergy tend to experience moderate to severe atopic dermatitis, and consuming wheat can trigger typical IgE-mediated reactions such as urticaria, angioedema, bronchial obstruction, nausea, vomiting, abdominal pain, and even systemic anaphylaxis. In contrast, allergic reactions to ingested wheat are relatively uncommon in adults. The most common form of wheat allergy in adults is wheat-dependent exercise-induced anaphylaxis, where symptoms arise from a combination of consuming the trigger food and physical exercise, or sometimes non-steroidal anti-inflammatory drugs or alcohol. In individuals with this condition, the gastrointestinal symptoms like diarrhea and bloating can be mild and hard to detect. Additionally, adult-onset wheat allergy often appears to be a temporary form of food allergy with a very positive prognosis. In one study involving 176 patients with wheat allergy, skin-related symptoms were observed in 69.3% of cases. The most frequent manifestation was urticaria or angioedema, occurring in 42% of patients, followed by eczematous dermatitis in 41%, which included atopic dermatitis, chronic hand eczema, and generalized eczematous dermatitis. Less commonly, generalized itching in 9% and psoriasiform lesions 8% were also reported. Now let's talk about non-celiac gluten sensitivity. Non-celiac gluten sensitivity is characterized by a range of symptoms triggered by the consumption of gluten-containing foods, which improve when gluten-free diet is followed in individuals who do not have celiac disease or wheat allergy. Although non-celiac gluten sensitivity is considered a distinct condition within the spectrum of gluten-related disorders, it shares some features with celiac disease, such as immune system involvement and the response to gluten-free diet, as well as symptoms commonly associated with irritable bowel syndrome. Autoimmunity like celiac and IgE-mediated allergies like wheat allergy do not appear to play a role in the pathogenesis of non-celiac gluten sensitivity. Instead, there is evidence suggesting the involvement of the innate immune system. Intestinal dysbiosis may play a role in the development of non-celiac gluten sensitivity by worsening epithelial barrier dysfunction and triggering an inflammatory response to gluten similar to what has been observed in celiac disease and other inflammatory bowel diseases. It remains uncertain whether gliadin is the primary cause of the disease as in celiac, as other wheat components such as amylase trypsin inhibitors and fermentable oligodimmonosaccharides and polyols, or what's called FODMAP, have also been suggested as possible triggers. Consequently, some researchers have proposed replacing the term non-celiac gluten sensitivity with non-celiac wheat sensitivity to emphasize that besides gluten, other potentially bioactive components of wheat and related grains are also eliminated in gluten-free diet. The term FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These short-chain carbohydrates are resistant to digestion and instead travel to the far end of the intestine where the majority of gut bacteria are located. The bacteria then ferment these carbohydrates, producing hydrogen gas and leading to digestive symptoms in sensitive individuals. FODMAP intolerance is particularly common among individuals with irritable bowel syndrome. The prevalence of non-celiac gluten sensitivity has not yet been precisely established. Based on self-reported data, it ranges from 0.5% to 13% in the general population, with a higher instance observed among women, teenagers, and individuals in their 30s to 40s. However, the absence of diagnostic biomarkers makes it challenging to determine an accurate prevalence rate. Unlike celiac disease and wheat allergy, non-celiac gluten sensitivity is still considered a diagnosis of exclusion, as there are currently no definitive serological or histopathological markers. The diagnosis depends on both negative criteria, ruling out celiac disease and wheat allergy, and positive criteria, symptoms improvement upon gluten withdrawal and recurrence upon gluten re-challenge in a blinded test. The clinical presentation of non-celiac gluten sensitivity is often non-specific and includes gastrointestinal symptoms like abdominal pain, bloating, and changes in bowel habits. These may be accompanied by systemic manifestations such as fatigue, headache, joint pain, and mood disturbances and skin issues. Symptoms typically begin a few hours to a few days after consuming gluten and tend to resolve once gluten is eliminated from the diet. Currently, only a limited number of studies have investigated the skin manifestations linked to non-celiac gluten sensitivity. One study reported that 1/3 of 276 non-celiac gluten sensitivity patients with symptoms resembling irritable bowel syndrome also had atopic dermatitis. In a follow-up study by the same research group, atopic dermatitis was found in 42% of the 60 non-celiac gluten sensitivity patients analyzed, with 10% of these patients also exhibiting nickel allergy with contact dermatitis. In another research, non-celiac gluten sensitivity patients showed non-specific, often itchy dermatoses that sometimes clinically resemble dermatitis herpetiformis, while others showed eczematous or psoriasiform features. A gluten-free diet appeared to lead to significant improvement or resolution of these skin manifestations. The lesions primarily consisted of erythematous papules and vesicles, often excoriated and intensely itchy, similar to those seen in dermatitis herpetiformis or subacute eczema. Some patients also presented with erythematous and hyperkeratotic plaques with excoriations. The prevailing complaint in all cases is pruritus, as in celiac-associated skin diseases. In the same study, the direct immunofluorescence of perilesional skin revealed C3 deposits along the dermoepidermal junction with a granular or microgranular pattern in 82% of patients. IgA deposits were observed in only a few cases without a specific distribution pattern, distinguishing non-celiac gluten sensitivity from dermatitis herpetiformis. The gastrointestinal symptoms in these patients were similar to those of irritable bowel syndrome that showed improvement following gluten-free diet. Skin lesions also resolved within a month for most patients after starting the gluten-free diet. The authors proposed the concept of cutaneous gluten sensitivity, which is characterized by itchy skin lesions, C3 microgranular or granular deposits at the dermoepidermal junction, and a rapid response to a gluten-free diet. In another study, 23.5% of 45 non-celiac gluten sensitivity patients presented with dermatitis herpetiformis like lesions despite having no gastrointestinal symptoms. All of these patients showed a microgranular or granular C3 deposit at the dermoepidermal junction again. Clinically, these individuals experienced itchy skin conditions that were unresponsive to conventional topical and systemic treatments but resolved quickly with a gluten-free diet. Also, 18.9% of the non-celiac gluten sensitivity patients had a history of atopic dermatitis, while 10.8% showed evidence of nickel allergy. So, recognizing specific skin manifestations associated with non-celiac gluten sensitivity characterized by distinctive direct immunofluorescence pattern could be beneficial for patient management, similar to the approaches used for dermatitis herpetiformis and celiac disease. The management of non-celiac gluten sensitivity primarily involves data restrictions of suspected triggers. However, there is conflicting data regarding the effectiveness of various dietary interventions, including gluten-free diets and low FODMAP diets. Despite this, current evidence suggests that a gluten-free diet remains the first-line treatment for non-celiac gluten sensitivity. Also, restricting FODMAPs may help to relieve gastrointestinal symptoms in some individuals. Further research is necessary to validate this observation. As a conclusion, gluten intolerance can manifest in a wide range of clinical symptoms, including both intestinal and extra-intestinal signs. It's recommended to screen for celiac disease and gluten sensitivity in patients who have unexplained dermatological conditions. A complete assessment of various dermatological conditions can reveal a link between skin and gastrointestinal issues, ensuring that significant gastrointestinal diseases in patients with skin symptoms are not overlooked. Strict adherence to a gluten-free diet is the recommended treatment for these skin conditions, as extensively supported by the literature. Lastly, I hope that you have enjoyed this video, and I'm reminding you again to subscribe to the channel and activating the alarming bell, and thank you.